All right, good morning, everybody. I know we had a lot of people sign up for this, and as you know, they'll be trickling in, but I think out of respect to all of us who are here on time, we're going to go ahead and get started, even if it's a few minutes late. So I'm Mark Froimson, and it's a real pleasure for me to moderate this symposium with my colleagues, who I'll introduce in a minute. And first, just thank you for coming out. Thank you for your interest in solving periprosthetic joint infections. I think, you know, we're both optimistic and humble. We're optimistic because we think that we have something special here, something that's going to make a real difference for our patients, something that may actually change the story of PJI. But we're humble because we want to hear from you. We want to, you know, we've all been told things like that in the past about innovation and advances. So, you know, we're not getting ahead of ourselves, but I think you'll hear a lot of data this morning about Prontosan, about PHMB that I think you'll find very compelling. I also want to thank our friends. We have a number of folks from B. Braun Europe and B. Braun Global who are here with us, who have been great partners in bringing this to the market. And I want to thank AAHKS for giving us a chance to do this. So with that, why are we doing this? Well, I think that surgical site infection, and particularly PJI, infections after joint replacement, is a modern tragedy. You think about it, patients are coming to us because they can't ski or because they can't play tennis or they want to improve their quality of life. And for those unfortunate few who end up with a prosthetic joint infection, it's a disaster. And I'll just go through this really briefly as an introduction. We don't know what the real number is. Everyone quotes something different. If you look at this paper, it says about 1% to 2%. Maybe it's 0.5%. We're not sure. Most of them develop early. But what we know is it's a real number. And if you operate on enough patients, you will have infections, unfortunately. And we also know it's the most common cause of revision surgery. So it is a real problem. It's not it's not something that doesn't happen. We're revising cases for infection more commonly than we're revising for any other reason. And the problem is, as you may know, the 5-year mortality from a prosthetic joint infection is higher than a lot of common cancers. So these patients don't do well. As much as we're trying to treat them and do what we can do, two-stage, single-stage, this carries a huge morbidity burden and a huge mortality burden. And the cost is quite high. So you're going to go out to the floor and you're going to see robots and AI and all kinds of expensive technology, and yet you'll go back to your institution and say, I want to use some surgical irrigation, and it costs $60 or $100, and they'll be like, that's too expensive. So we have robots that are trying to incrementally change alignment, maybe get range of motion a little bit better. I'm not against it, but we have to be focused also on the biggest problem that we have not yet solved, which is infection. Our mission, and this is why we're doing this, is to get it to 0. 0 is not unattainable. And I would ask you a question. Let's assume the number is 1% or 0.5%. Would you have flown down here if they told you when you got on the plane that it had a 1% chance that it wouldn't land safely? I mean, 1% is high. 1% is a lot. There are 24,000 commercial flights in the U.S. every day, 80,000 altogether. Imagine if 1% were crashing. Imagine if 0.001% weren't landing safely. They'd shut the industry down. And yet we have an industry where 0.5%, 1%, call it what you will, patients coming in for elective surgery are ending up with a severe problem. And this is the data. It's much safer to fly than it is to drive. There hasn't been a commercial airline accident since 2009. And you can see that little circle. That was the one accident. And otherwise, you know it's very safe to get on a commercial flight. So I'm going to go through this very quickly. The point here, because our speakers are going to really speak to this, this is a statistical contest between the host and the offending microbes. That's all that infection is. It's a contest. And these wounds get contaminated, and we have to resist the infection. And we know OR contamination is real. We've measured it. We know that despite sterile technique and all the things that we try to do, there's still, if you put a culture dish out in the OR, it will be positive for bacteria. And this isn't a new recognition. This is from 1957. Wound contamination, we've known about it. We've just not had an ability to really address it in an effective way. And we know about it. We use prophylactic antibiotics, right? Why do we use those? Because we know that at some point during the procedure, there's going to be bacteria in that incision. And we hope to prime the host, but we have to use wound irrigation, and I think we're seeing this. The choice of agents matter. Others are going to talk more about this, so I'm going to skip it. But we came upon polyhexanide, PHMB, and the purpose of this symposium is to make you aware of it, make you understand this is a choice that you have. I'm wearing contact lenses. It's in contact lens solution. It's incredibly safe. It's in cosmetics. It's in the food industry. This is a widely used chemical to prevent bacterial overgrowth in a huge array of industries. We've just not seen it in orthopedics. So we're thinking, well, what is this? It's something new, it's something strange. It's really been out for a long time. It's very similar to CHG, but it's kind of detoxified. It's much safer than CHG. You don't have to rinse it out. The body likes this stuff, and you'll hear a little bit more about that. I'm going to skip this because, how do you choose an irrigation solution? Some of our speakers are going to address this. But what I want to leave you with, and I want you to think about, do any of you use tranexamic acid in your practice? Right? Everybody does, right? Everybody uses it. But if you go back 15 years ago, nobody used it, right? Transfusion rates were somewhere between 10 and 30%. It was one of the reasons you really couldn't do surgery in an outpatient center. Everyone thinks that the move to the ASC has been because of all kinds of other things, but it's really because of TXA. It's really the fact that we can confidently operate on people and know that we don't have to transfuse them. But you'd never heard of it. It was identified in 1962. It was used in other areas of medicine for a long time, and then one day it was discovered, 2008. And now transfusions are extraordinarily rare. They happen, but they're rare. So the question I have is, and what I'm hoping is, can this same story play out for PHMB? Can we take a chemical that was known to be safe, is used extensively, we have a broad experience with it, and maybe finally we can get the number of periprosthetic joint infections down significantly. So we have a great faculty. We have myself, with the exception of myself. We have Curtis Hartman from Nebraska, Steve Percival, who is going to come in via Zoom from Manchester or Liverpool, England. Paul Jacob, one of our former fellows who set the bar so high no one else has been able to get there. And one of my former partners, Viktor Krebs, all very well recognized experts in this field, so we're really delighted to have them. Here's our agenda, but without further ado, I'm going to ask Curtis Hartman to come up and give his talk. Thank you.
Are we good there? Okay. I'll wait for my slides here. I didn't prepare any jokes, so we'll just have to wait. Well, good morning. Thanks again, Mark, and to all of you for being here. It's a real pleasure to be on this panel. I've been tasked with discussing the optimization of the patient and the surgical environment to reduce prosthetic joint infection. I do have some disclosures to point out. Moving past those, I think the best way that I like to think about patient optimization is to think about the continuum of care. So what are the things that we can do in the preoperative period, things like risk stratification and optimization of those risk factors. Then I like to look in the perioperative period. So what are the things that we're doing in the operating room immediately before they get in the operating room, immediately after, And then at the end, after surgery, what are the things that we can do to mitigate what we know are some other risk factors in that post-operative period? So we'll go through several of those areas and hopefully give you an overview of how I like to approach this. So I do think that the first step is really understanding what the risk factors are for your patient. There have been a whole lot of studies that have looked specifically at this, and we know there are a whole bunch of different risk factors. I think it's helpful to look at those risk factors as either modifiable or non-modifiable. So unfortunately, a lot of the risk factors that we're aware of are actually not modifiable. So we can't really change someone's race, their gender, their socioeconomic status. But we can really focus on these modifiable risk factors. Things like obesity, their glycemic control, their nutrition, whether or not they're using nicotine products. And when I'm counseling patients in the preoperative period, I talk to them about this modifiable versus non-modifiable risk factor. And I am very clear to point out that a risk factor may be modifiable, not necessarily easily modifiable. We all know that obesity is not necessarily easily modifiable. Nicotine use is not necessarily easily modifiable, but it certainly is something that they can change if there's enough desire. So decolonization, I like to start there. We know that 25 to 30% of patients who are going to have a knee replacement or a hip replacement are colonized with Staph aureus. There have been several studies that have looked at decolonization protocols that have been effective at reducing SSI. A couple of those use chlorhexidine gluconate and nasal mupirocin. This was a study done at Washington University where they looked at treat all protocols versus screen and treat. So the idea there is if you screen everybody that's coming in, culture their nares, and if they're positive for Staph aureus or MRSA, then you decolonize those patients. When they compared that cohort to a cohort where they had actually treated everybody, they found that the treat all protocol actually resulted in fewer infections and, interestingly, lower cost. The cost of actually doing the decolonization is fairly inexpensive. It's just a minor bump in the cost of, the total cost of a joint replacement. So treat all protocols seem to be what's come into vogue and really supported by the data. This is what we're doing at our place now. We don't bother screening, we just treat everybody. So obesity is one of those risk factors that unfortunately I spend a lot of my day talking about when I'm in clinic seeing new patients. Again, many studies have demonstrated that obesity is a potent risk factor for PJI. And it seems to be beyond linear. It's almost like if you plot out the curve of infection versus PJI, once they start to get above 40 or 50, that risk for prosthetic joint infection really starts to climb. What's interesting is we do know that obese patients actually do very well after joint replacement if they don't get an infection. Their satisfaction and functional improvement is as well, if not better, in several studies compared to non-obese patients. I think the bigger question is, how about short-term weight loss? Does that help? And it appears that short-term weight loss probably is not protective against prosthetic joint infection. This was an interesting study. They looked at a large database cohort, and they looked at patients who had a BMI of 45 to 50. And if they had weight loss more than a year before their surgery, that was actually protective against prosthetic joint infection. But what was really interesting to me was the cohort. So they looked at a cohort who had weight loss in the 3 to 6 month range prior to surgery. That was actually the highest risk cohort. They actually had a greater risk of prosthetic joint infection than the group that didn't lose weight. So it appears that while weight loss can be beneficial, the timing is probably important. And I think this leads to the idea that patients come in with a BMI of 50, we tell them they have to get to a BMI of 40 or whatever your number might be, and they go on some drastic diet and they become malnourished, and then that increases their risk of infection in the short term. If they can do it over a long term, it's probably a healthier way to go. So that brings me to the nutrition aspect. What is fascinating is if you look at obese patients who are undergoing arthroplasty, Almost 50% of those patients are malnourished, what we would call paradoxical malnutrition. This appears to be because the way their diet, the way they consume calories, it's a lot of calorie-rich but nutritionally poor foods, so lots of fats, sugars, low complexity carbohydrates. But I think beyond those patients, you have to pay a special attention to the elderly, patients with substance abuse history or substance abuse disorders, patients with GI problems who are malabsorbing vitamins, and then lastly, cancer patients. That's a particularly high-risk group, so pay close attention to those patients when you see those. Numerous authors have looked at how to screen for malnutrition. I think the most commonly used tool right now is probably albumin, but I've listed several here. Total lymphocyte count less than 1,500 has been used by several authors, and a transferrin level less than 200. So just any of those patients at risk ought to be screened, and if they screen positive, then you can refer those patients on to a dietitian to work on their diet prior to joint replacement. Well, what about glycemic control? Again, this has been studied extensively. There are a lot of studies that have looked at, is hemoglobin A1C a valuable marker as a risk factor for prosthetic joint infection? It does appear to be helpful. There's not a great cutoff point. You can look at 7.5, 8, 8.5. There's a lot of debate. I don't think the literature is entirely clear. What we do know is glycemic control is important. People who have poor blood glucose control, especially around the time of surgery, are at increased risk. So a couple of interesting studies looked at patients with a diagnosis of diabetes, and they compared those who were well controlled to those who were poorly controlled. And as was a surprise to no one, is the poorly controlled diabetics had a higher risk of prosthetic joint infection. But what I found interesting is patients with well-controlled diabetes actually have no real increased risk compared to healthy controls. And another interesting study found that even patients who have never been diagnosed with diabetes, if you look at their perioperative blood glucose, so if in the PACU they have a blood glucose greater than 140, that cohort's at significantly increased risk for PJI. And that literature actually has been, or that data has been extrapolated in multiple surgical disciplines. So we know in ICU patients, cardiac surgery patients, general surgery patients, trauma patients, they all have increased risk of surgical site infections if they have poor perioperative blood glucose control. Well, nicotine is one of those that also seems to be a difficult conversation for many of us. There have been several studies looking at this. I think this meta-analysis was really helpful. They actually found an odds ratio of 3.7 for PJI risk in patients who were using nicotine. Again, similar to weight loss, smoking cessation does appear to reduce the risk of prosthetic joint infection, although they looked at this at the University of Iowa and in a very large database study and found that former smokers compared to non-smokers actually had increased risk of infection. So that was a database study, a little bit hard to control for how long a patient had been a former smoker. So I don't think there's clear guidance on a timeline, but for me, nicotine use is a hard stop before an elective joint replacement. I just tell the patients, look, there are a lot of risk factors that we can't control, and there are some that we can. This is a risk factor that we definitely can control. It is nicotine products in general. It's not just smoking. So I make sure my patients are completely abstaining from nicotine for 6 weeks prior to elective surgery. And then inflammatory arthropathy. So fortunately, the advent of a lot of these medications the rheumatologists are using now seem to have helped tremendously with patients suffering from inflammatory arthropathy. So we're actually seeing a lot fewer of those patients needing joint replacements. But there are still some, and I think, as the number of medications that come out to treat rheumatoid arthritis and other inflammatory arthropathies just explodes, it's a bit dizzying to the orthopedic surgeon when you see these patients. I mean, it seems like once a month I see somebody who's taking a medication for RA or psoriatic arthritis that I've actually never even heard of. Like, I've heard of the class, but have never heard of the medication. So the American College of Rheumatology and AAHKS actually published guidelines on this in 2017, and then this was recently updated in 2022. This is a great paper. I would highly encourage you to use this as a reference. They went through all of the major classes of these drugs, and then specifically looked at lupus, and if the lupus was severe lupus, how you adjust the medications. I would say the take-home message from this guideline paper is that traditional DMARDs, so things like methotrexate, hydroxychloroquine, doxycycline, those can be given throughout the perioperative period. There's probably no indication to hold those. Where you really want to be careful are on the biologics, the immunomodulators, and there are different classes of those, but the general consensus is, depending on the dosing regimen, so if it's a 3-week cycle or an 8-week cycle, you schedule their surgery at the end of a dosing cycle and then hold that dose. So if they take a medicine that's given every 8 weeks, they take their medicine, then 8 weeks later you do their joint replacement. You hold the medication until the wound's healed, and then you can resume that medication usually safely. So Mark talked about this a little bit, prophylactic antibiotics. There's very clear evidence supporting the use of prophylactic antibiotics in the perioperative period. First or second generation cephalosporins appear to be superior. The current AAHKS recommendations are for a 24-hour period of prophylactic antibiotics. What's interesting is a couple of meta-analyses actually found that there's no benefit to 24 hours of antibiotic therapy versus a single dose. There is a level 1 study that just completed enrollment at Duke. We're waiting on that data for publication, but it appears that probably one dose is as beneficial as 24 hours, but just hold your judgment on that until a little more time and studies are available for review. I think another interesting thing, and this has really changed in the last probably 10 years, a penicillin allergy is not a contraindication to the use of cefazolin. The 2019 Charnley Award from the Mayo Group, they looked at this and they compared patients who had prophylactic antibiotics with something other than cefazolin and those who did have cefazolin. And the non-cefazolin group had a significantly higher risk of prosthetic joint infection. So unless the patient has a true allergy to cefazolin, they should receive first or second generation cephalosporin. If you need additional antibiotics, if they have MRSA, you can certainly add something like vancomycin, but they should also get cefazolin. All right, so what about skin preparation? So there are lots of studies looking at various skin prep agents on the market. There's pretty good data on the use of chlorhexidine gluconate wash in the preoperative period. So our protocol is currently 5 days of chlorhexidine gluconate bath to the affected extremity. We remove the hair in the preoperative area with electric clippers. Don't use a razor. Razors are associated with increased skin trauma, which releases bacteria from the hair follicles, and that increases the risk of prosthetic joint infection. We like to use a combination agent with ethyl alcohol and iodophor. There's also combination agents with CHG and hexachlorophene. All of those seem to work very effectively. The use of alcohol is as a potent antibacterial agent. Those additional medications just help prolong the effective time of the ethanol. I also believe strongly in the use of incised drapes. There's some data supporting this. The use of an iodophor impregnated drape actually has been shown to decrease lateral bacterial translocation in these wounds. And what I like about it, especially in the hip, is it gives us the ability to effectively occlude areas of high bacterial colonization. So we can block out the perineum and the rectum area with these drapes. So I use those routinely. And then we're going to hear a lot about wound irrigation today. As you guys are aware, there's a lot of different solutions that are available on the market. Currently, povidone iodine is the only solution out there with level 1 data. That was a paper out of Rush that studied that. That was in revision total hip and knee arthroplasty, not in primary hip and knee arthroplasty. The one thing I really like about Prontosan is it's the only solution on the market that doesn't require some additional irrigation after treatment. So especially in our current era after Hurricane Helene, and at least in our hospital, and I'm sure with the rest of you, we're being very, very cautious about the use of saline. So we're using Prontosan in all of these cases to avoid the necessary use of saline to try to save that. So what about airflow? So this has been one of those subjects that's been debated back and forth for years. Several laminar airflow studies have shown an improvement in the risk of PJI, but unfortunately several studies actually showed an increased risk of PJI. And Mark alluded to this as well, the OR environment. There are numerous studies that have shown OR traffic significantly increases the number of airborne bacteria in the room. And when you look at door openings in particular, every time the door's opened, it changes the airflow pattern and creates a whole bunch more airborne bacteria. And the majority of those door openings are unnecessary. So in a modern era where we have lots of technology to help, we're able to keep implants and instruments in the room. You really should institute policies in your institution where you're absolutely only opening the door when it's 100% necessary. If somebody wants to come in and check on the nurse to see if they need a break or the circulator, or especially anesthesia in and out all day long, offering to go get a coffee, just really try to put the kibosh on that. We use signs like this in our OR to try to minimize the number of people running through there. Body exhaust suits, this is another one that's sort of gone back and forth over time. We know that most of those bacteria, the airborne bacteria, come from shedding from the OR personnel, so the body exhaust suits were developed to minimize that. They actually are effective at minimizing the number of airborne bacteria. I think the bigger question is, do they actually then minimize the risk of prosthetic joint infection? Several studies have suggested they do not. But what we do know is that it's a very effective fluid barrier, so it helps protect the people in the operating room, and that's really the primary reason that I use. I shared a picture of myself and one of our former residents. As you guys know, these cases can sometimes get pretty messy, and there's lots of blood and fluids flying around, and so just as a way to protect your OR personnel, I think body exhaust suits are pretty beneficial. So this is an interesting topic that's come up recently, extended prophylactic antibiotics. So now we're moving into that post-operative period. So we published a couple of papers. We studied the use of extended prophylactic antibiotics after two-stage exchange, and we found that there was a significant improvement in the risk of recurrence in those patients who had a short course of prophylactic antibiotics. So Michael Meneghini and his colleagues in Indiana studied this, looking at the high-risk primary arthroplasty cohort. And so what they defined as a high-risk patient received a 7-day course of oral antibiotics. They did find a significant reduction in short-term infection risks. This was a retrospective cohort study, so actually when you read this paper, they were very clear to caution us that this shouldn't be adopted widely without further level 1 studies. We really need a couple of randomized controlled trials of this particular question before I think this should be adopted widely. Blood management, again, this is something that really has changed a lot in the last 10 years with the advent of tranexamic acid. An allogenic blood transfusion is an independent risk factor for prosthetic joint infection. And we know that restrictive transfusion policies can significantly decrease the risk of transfusion without affecting patient morbidity or mortality. So I think what's really changed about this is in years past when I was training, we had some randomly assigned number, like their hemoglobin's 10, they get 2 units of packed red blood cells. Now we're really trying to use physiologic transfusion triggers. So even if their hemoglobin's 8, if they're asymptomatic, you don't necessarily need to transfuse that patient. And with the use of TXA, we're seeing fewer and fewer transfusions anyway. I think probably the other thing that's really, really important is screening those patients preoperatively and managing their anemia before they have elective surgery so that you can avoid this risk. Wound management, we know that prolonged wound drainage is a significant risk factor for PJI. So we aggressively manage any draining wound. I think there's some evidence that closed incision negative pressure wound therapy is beneficial in high-risk patients. We recently completed an RCT at our place, and we're still analyzing the data, but it does seem to be beneficial. I think the jury is still out on primary arthroplasty. There's not a lot of level 1 data on its effectiveness in those patients, but there's probably high-risk patients that do benefit from that. It just needs some time for definition. The last thing is anticoagulation. I think you have to be very cautious with aggressive anticoagulation. This is one of those complications that we're trying to avoid. It appears that 81 milligrams of aspirin BID is safe and effective. The PEPPER trial, which many of you are aware of and are involved with, is nearly complete. We're expected to finish enrollment later this year, and so we'll have a good answer on this. I think the real problem is in the patients who are at high risk for DVT and PE, the patients who have poorly controlled atrial fibrillation or have a prior PE. You have to work closely with your medical teams. They all want to put them on a high-dose therapeutic DOAC on post-op day 1, and those patients are at significant risk for bleeding complications. So we really try to negotiate with our internists and really look into their clotting risk, especially if it's AFib. You can look at their CHADS-VASc scores, and if they're not super high risk, then you can really dial back on the DOAC to at least a prophylactic dose rather than a therapeutic dose. So in conclusion, I think it's really important to develop systems and processes to screen out those high-risk patients. You will, I think if you can spend a lot of time counseling your patients and really informing them of the risks of complications, that's beneficial. I think no matter what we do, you're going to continue to have some patients with complications. And if you've taken that time and you've really explained the risk to patients, then God forbid when a complication does occur, at least they feel like you've given them all the information they can handle. I think the last thing I want to say is prevention is the best cure. If we can prevent most of these by being smart on the front side, then we can prevent a lot of these complications at the end. So thanks for your time.
Yeah, so that's a fantastic overview of like the concept of this is you really need great systems in place to really think about all of the host factors, environmental factors, and surgical irrigation is an important factor, but it's not the only factor. And I think we really wanted to spell that out here. We're not advocating for Prontosan in lieu of everything else. It's a part of a comprehensive protocol. So now we're going to turn. Hopefully Steve is ready in the next 15 minutes or so. Steve Percival, Dr. Percival from England, is going to give us a comprehensive view of the basic science and really kind of the rationale of the mechanism of action of betaine and PHMB and the way Prontosan works. So, Dr. Percival.
Lovely. Thank you very much indeed, and it's nice to be speaking to you from sunny England. Over the next 20 minutes, I'm going to give you an overview in reference to microorganisms, biofilms, and touch on these irrigating solutions that we're talking about today. But when we think about microbiology, what we always have to bear in mind, we're dealing with bugs that are either swimming around, and these are called planktonic bugs, or we have bugs that attach onto a surface. And when they're attached onto a surface, they're called sessile, and they grow into these things called biofilms, which really has only entered the medical profession, I'd say, in the last 15 years. So these microorganisms actually exist in both states. But of course, without being too anthropomorphic, what we've got to bear in mind is that bugs do prefer a surface because there's a number of reasons ranging from protection to getting a food source, and also in terms of interacting with other microbes, because there is a lot of biological warfare that's happening in the human body as well as externally to the body. So there's natural competition going on all the time with different bugs. And of course, when we look at the human body, we know we have different sources of microorganisms that are in the gastrointestinal tract, the urogenital tract, the mouth, the skin. And we know these are moving around all the time and they're very diverse. And of course, what can happen is when you get these bugs in different parts of the human body where they shouldn't be, ultimately they lead to problems. So, for example, in this diagram here, you'll see different areas whereby medical devices have been put into a host and they've got a biofilm related infection. So, number 3, for example, is keratitis of the eye, often due to acanthamoeba. And these often grow as biofilms on contact lenses. You'll get cochlear implants, you'll get biofilms on tricuspid and bicuspid valves. A major one on number 7, of course, are intravascular catheters, where the bugs actually grow interluminally inside those catheters. So we develop these catheter lock flush devices that hopefully try and remove biofilms. So anything from a prosthetic perspective has the ability to allow bugs to grow on them and then ultimately over time grow as a biofilm. But if we get a biofilm, that represents a major issue in terms of managing those microorganisms. So when we look at the host and we look at biofilms in general, we have them throughout the human body. So a good example may be the tongue. Another one may be your teeth. And imagine what we do to our teeth all the time to manage that biofilm. So we brush our teeth in the morning. Some people may use the mouth rinses as well to keep the microbial load down. We can get them, as you know, on your urinary or causing urinary tract infections, particularly forming on Foley catheters where they cause encrustation due to a bacteria known as Proteus mirabilis. And of course, that will block up the inside of the catheters and ultimately lead to an infection. We get them in our drinking water, and these are tubercles that you find on cast iron pipes on the right-hand side there. And these are very thick biofilms that you can physically see. Again, on ships' hulls, these form and will increase the drag on ships. Ultimately, that will lead to global warming because those biofilms increase the drag. And for that boat to move faster in the water, it has to use more fuel. So this is a major issue in terms of biofilms. Endotracheal tubes, as you know, ventilator-associated pneumonia is linked to biofilms, particularly on the dead legs there, on endotracheal tubes where you'll get biofilms being formed. And even in your toilets, there's a lot of work taking place on detergents and disinfectants that control biofilms there. So we've got to then establish how biofilms form, and they will form in acute wounds, in chronic wounds. Any incision that's made, if there's microorganisms there, they have the ability to proliferate, contaminate, and colonize a surface. But the idea is we don't want those bugs to actually start multiplying, growing, and causing problems to the host. So when bugs are in the vicinity of a surface, but bear in mind that bugs don't have to attach onto a solid surface to grow as a biofilm, but when they're around, they can attach to each other and start multiplying and growing, and they can then attach onto a surface as well. And once they're on that surface, they start coating themselves in extracellular material, and that aids their protection, and that becomes like a living organism inside the host. But we always have to remember when biofilms are forming, when the bugs attach onto a surface, often they're not attaching to that surface per se. They're attaching onto a thing called a conditioning film. So anything you put in the human body will be conditioned straight away with proteins. So those bugs are actually attaching to that conditioning film, not the surface per se. And when you have a shower tonight, by all means, look at your shower heads and you'll see that there's biofilms inside your shower heads that may contain mycobacterium as well as Legionella. So it's always something to think about as well as when you have your drinking water here in the drinking water pipe. The issues with biofilms are numerous, and I won't go through all this, but in terms of a medical issue at the moment, the major issue you have with biofilms is their tolerance to antimicrobials. So once these bugs start growing on a surface, what happens is they become very recalcitrant towards topical antiseptics as well as systemic antibiotics. And if you've got patients that are very ischemic, of course, those antibiotics can't get to the site by where the biofilm has formed. Now, this is only a tolerance, it is not a resistance. So what this means is once the bugs are in the biofilm, they can be up to 1,000 times more tolerant to that antimicrobial. But if you take them out of the biofilm, you can kill them quite easily. It's similar to how you'd kill them in the planktonic state. But this tolerance isn't genetic. So it can be due to the structure of the biofilm. It can be due to the fact that bugs within the biofilm become very slow growing or dormant. So any actual antibiotics that require a bug to be multiplying, if these bacteria go dormant, things like penicillin won't work because, of course, they work on their cell wall. So we have to bear this in mind. We don't want a biofilm being formed because it becomes very problematic to kill these bugs. And within 10% of any microbial population, we have these things called persister cells. So anything that's reoccurring in terms of infection, we have this population we can't kill. So when we think about these persister cells, if we apply an antimicrobial to them, what will happen is you'll select for these more tolerant microbes. And if you take away that selective pressure, what will happen is you'll get regrowth. So any form of infection, any chronic condition that keeps reoccurring, you know you have a biofilm, and that becomes very problematic. So you can look at various markers to determine whether you have a biofilm-related surgical site infection that you're trying to prevent. And all these potential markers, if you have them, ranging from recalcitrance to antibiotics, ranging from reoccurring inflammation or chronic and localized infection, these are very strong indicators you have got a biofilm. So that becomes a different way to manage that patient, because then it becomes guided biofilm-based management then in terms of that patient. So when we look at prosthetics and biofilms, we know that a lot of these biofilms, these are the things that are causing or having effect on the infection rates. And infection rates are exceptionally low in terms of the prosthetic joint infections compared to things like chronic wounds, of course, particularly when you have patients with diabetes who get diabetic foot ulcers. So what we have is an awful lot of evidence that biofilms are found on prosthetic devices, of course. So there's a major emphasis to try and control these adhesion of bugs onto these surfaces, as well as controlling biofilms. But even when biopsies and swabs are taken, often these recover no microbes, and they're often culture negative, because what happens is when bugs grow in a biofilm, they change their whole physiology and they take a longer time to grow on agar plates. So when you're looking at antibiotic sensitivity, for example, to determine which bacteria is causing the problem, you'll find that often you'll have to leave that plate incubated for a longer period of time to determine which is the major problem bug here we're trying to manage. So as I'm saying, when it comes to biofilms, when it comes to microorganisms, you want to try and stop them attaching onto the surface. You want to try and stop them forming a biofilm, because that causes major problems to the patient and becomes a clinical challenge because there's so many variables you're dealing with. So we have to apply different methodologies. And one, of course, that's employed routinely is irrigation when there's any sorts of prosthetic device going into a patient. These play a critical role in terms of preventing the formation of biofilm. If a biofilm is starting to form, they can help disruption. And of course, it's crucial that these irrigation solutions have some form of antimicrobial effect. Of course, this will help clear the actual bugs from where the site is being operated on. So we look for some ideal sorts of solutions that can be applied in these situations. So we're looking for solutions that can get at least a log 4 reduction. So the FDA have guidelines, of course, when you're developing an antimicrobe, to call it an antimicrobial, you have to achieve a log 4 reduction in terms of that microbiological load. We also have to look at the cytotoxic effects of these antimicrobials. So as we know, when you develop a product, we have to do biocompatibility testing, and there's cytotoxicity studies that have to be undertaken. So it's important that we don't have a major effect on the patient's cells, because they're important for the healing process, of course. But we also have to make sure, when it comes to antimicrobial stewardship, that we are dealing with antimicrobial agents that have a risk both to society, the patient, and also have an effect on what you're selecting for in that patient. And if you don't know the limitations of antimicrobes you're using, that will be classed as inappropriate use, because these limitations will affect the therapeutic effect of these antimicrobes, particularly on biofilms. And there's a lot of synergy between antimicrobes as well. So a very important one is organic matter. And what I mean by that, if this everything in terms of an antimicrobial performance is affected by a biological demand. So if there's lots of biology there, lots of cells, you will reduce the efficacy of that antimicrobial. Contact time is exceptionally important. So you have to leave the antimicrobial in contact with the bugs for an appropriate amount of time for it to become effective. So like during COVID, of course, we were using disinfectants all the time. A lot of people weren't leaving them on the surface for long enough to actually kill the bugs. And they were being wiped off very, very quickly. And ultimately, what that will achieve is you're not reducing the numbers of bugs on those surfaces. Concentration of the antimicrobe is very important. You want to reach therapeutic levels. But when you have a biofilm, bear in mind, when you do an antibiotic sensitivity test, that is not bugs on a biofilm. So when you're using an antibiotic, you have to bear in mind, you have to increase the concentration if you have a biofilm-related infection. And as we know, a major thing now, particularly with antimicrobial stewardship and anybody producing an antimicrobial, the requirements by the FDA are, you have to now show that that antimicrobial you're using doesn't have a cross-resistant effect on enhancing antibiotic resistant genes. And of course, there's no standards for this, and we have to look at genetics, etc., genomics, to understand which genes are being switched on. But it's very important that the use of things like chlorhexidine, for example, which is known to cause a cross resistance, as well as triclosan, as well as benzalkonium chloride, these things, of course, now are not put in like cosmetics because of this issue. So this is very important when you're evaluating which antiseptic to actually use. So the objectives really in the management of any sort of prosthetic joint infection, an irrigating solution is used to reduce the microbial load. The idea is you don't want a biofilm to form, so you're trying to prevent that. And to prevent that, you've got to prevent bugs attaching. You've got to have something that will support the natural healing process of the body and optimize that. And of course, you want to prevent regrowth, hence why you brush your teeth. You're preventing those biofilms from keep reoccurring all the time. So key irrigating solutions that are employed regularly are things like chlorhexidine, your guainides, your PHMBs, your povidone iodines, as well as saline. And there are a bunch of others that particularly are used in Europe, probably more so than the US. So when we look at the pros and cons of these, we'll have a different array of positives and negatives. So chlorhexidine, for example, is an array of data out there showing that it's very effective on skin, and it's employed particularly for skin preps as well as iodine. However, we know that chlorhexidine is very cytotoxic, particularly at high concentrations. There are issues with cross resistance, and when it's used as an irrigating solution, we know that has to be washed out or irrigated out with saline to reduce this cytotoxic effect. Similar to that of iodine, of course. Again, iodine's very effective. It's particularly when it's used for dog bites as well. That's the standard protocols of care in the UK. And we know that it can be very good on biofilms. There's, I think, only one incidence of resistance to iodine that occurred in the 70s, so it has a low level of resistance. But again, this one can be affected by organic matter, and again, it can be very cytotoxic. Another one is saline that's used routinely, generally regarded as safe, of course, but unfortunately has no antibiofilm abilities and has no effect on microbes. So then you move on to PHMB, of course, and a lot of these PHMBs are combined with surfactants that are very important. And we know they have a broad spectrum of activity. They're generally very low in cytotoxicity, and different to the other ones, this doesn't need to be washed out of the wound, of course. And it seems to be very efficacious even when there's presence of organic matter. So it's been shown to be very effective in terms of killing bugs in the planktonic state as well as within the biofilm. Surfactants are very important when we look at these irrigating solutions now, because surfactants change the surface tension between surfaces. And these surfactants have the ability to prevent microorganisms attaching onto the surface. So you'll find things like Prontosan have a surfactant called betaine, but also don't forget PHMB is a surfactant as well at low concentrations. And there's even evidence to show that it can help with cellular reinvigoration, particularly cells that are undergoing necrosis, not apoptosis, but they've been shown to reinvigorate some cells. So these surface active molecules are very important, of course. And they become more important if you leave them, particularly on hardware, provided they don't cause any corrosion. But what you'll generally find is, as I said, anything that goes in the human body will be conditioned with a film. And that is generally protein, which deposits on that surface very, very quickly. So any micro contouring, any surface changes you've made, these can be counteracted very quickly when they're put in the body. So what you're trying to do, if you can get a surfactant on the surface, what will happen is a bug, when it goes to a surface, twitches a lot and determines whether it will attach and stay there. If you've got a surfactant on there, what will happen? They will actually detach from that surface because it's not favorable for them to grow on. And if they can't attach, they can't form a biofilm, you won't get regrowth, and you're preventing the formation of a biofilm, which is very beneficial as that hardware is in the patient. Now, there's lots of studies that have been taken place on irrigating solutions, and one study looked at irrigating solutions such as Prontosan, which has the PHMB, Irricept, which has the chlorhexidine, Experience, which of course has citric acid, and Sure, which has the povidone iodine. A study was taken place to look at these bugs in more dirty conditions. And what I mean by that, they've got lots of protein and blood in them, and it's following a standard. And the idea is, if you can achieve a log reduction of 5 in more dirty, more realistic conditions, these have been shown to be very effective in terms of the human body. So when you study all these irrigating solutions, you find some can be very effective very, very quickly. So Prontosan, for example, within 1 minute is achieving a log reduction of 5, particularly against Staph aureus, compared to the other irrigating solutions. Been the same with Enterococcus, the same with Pseudomonas aeruginosa, and of course they can vary depending on the bugs you're dealing with. And we're continually getting significant antimicrobial effects with Prontosan compared to some of the irrigating solutions. And as you're following a standard procedure here, everything is standardized and you're getting more realistic data here that can be applied to the patient. And Cutibacterium, of course, used to be propionyl bacteria, acnes, again, very effective on that, which is often very hard to kill. We also know, if you look then at these different solutions on biofilms, we know we do get a reduced effect on biofilms, which happens with any antimicrobial. But of course, what you're finding against Staph aureus and Pseudomonas aeruginosa, Prontosan is having a significant effect of here. The PHMBs have an effect. And we can study these actually under confocal laser microscopy. So if you have a look on the left, this is a biofilm where all the bugs are living, so they're staying green. We then apply a PHMB solution, and after 24 hours, the bugs and the biofilm are being removed. And once they go red, those bugs are dead. So we can show in real time how quickly we're killing these microbes and killing the bugs within a biofilm on a surface. So that ultimately shows that effect there. And what we've got to bear in mind as well, when we look at biofilms, and if they have actually formed, as you can see here, there's a biofilm here, we really want to get rid of them very, very quickly because we don't want them to carry on growing. However, if you're coming to manage a biofilm, you have to look at the collateral damage that you're causing. So a biofilm is kept together with extracellular polymeric substances, which are polysaccharides, proteins, and metal ions. What happens is if you break up a biofilm, these enter the human body and they're very immunogenic. So you can prolong the inflammatory response here. You release lots of toxins and enzymes, biofilms are released, metal ions, aggregates of microbes, extracellular DNA, and all these have an effect on delaying the healing process, increasing risks of infection throughout the body of that patient. We also have to bear in mind as well, when we're looking at these irrigating solutions, we've got to get a nice balance between the antimicrobial performance and the effects they're having on mammalian cells. And we call this a therapeutic index. And this is, of course, is what is used for drugs. And it's only slowly now getting into the arena of antimicrobials. And what we've got to make sure is that you're getting maximum therapeutic effect on killing the bugs, but at the same time having low cytotoxicity in terms of effects on cells. And what we do know when we look at therapeutic indexes and when we look at, often it can be called the biocompatibility index, but we know from reports out there that things like povidone iodine, chlorhexidine, sulfadiazines that are used in wound care, these can have quite a low therapeutic index, whereas things like PHMB have a high one, which means they're very effective at killing bugs and they have a low effect on human cells. So you're getting a good balance in terms of improving the healing process. And as I mentioned before, it's very important that we understand any cross-resistant issues of antiseptic usage and that of switching on and selecting for antibiotic-resistant genes. So there's lots of documents out there, lots of papers which can show you the major antiseptics that the FDA now are looking at, whereby if you get to sublethal concentrations of those antiseptics, they can actually switch on antibiotic-resistant genes. So in conclusion, when you're looking for the right irrigating solution, it's very important we have this biofilm issue in mind, that we're trying to prevent that being formed, but at the same time trying to stop those microbes attaching. So when we look at performance, we can highlight which are the most efficacious there preventing biofilms. We can look at the ones that are less cytotoxic, and we look at the clinical considerations there on which one is providing good, solid clinical evidence that they are effective. And reducing a step in the irrigating solution is very important. So, for example, as I said, you don't have to wash out PHMB. And because it has this surfactant effect as well at lower concentrations, that's aiding the actual prevention of those bugs attaching onto hardware and risking that patient from getting an infection. Thank you very much indeed for listening, and I hope there was something there that may be useful for you.
Great, thank you, Dr. Percival. I don't think you'll hear that kind of a basic science lecture anywhere else in this meeting. And I mean, but it's really important stuff, and it shows you how much work has been done on this molecule that none of us had ever heard of until recently. But now we're going to shift gears, and Paul Jacobs is going to tell us about, after hearing all that, why he uses this and what his results are. Probably the most experience of anybody in this country with Prontosan. So Paul, thanks for being here.
My pleasure. I appreciate you guys having me today. I'll just give you a quick background. I'm in private practice. I'm at a physician-owned hospital system So I had to fight for getting this product into my hospital, even though I'm the one still paying for it. It was that important to me. I'm very passionate about this. I do about 1,300 primary and revision cases a year, so we get a lot of data, and hopefully we'll show you some of that. It's pretty compelling data. So here are my disclosures. Interestingly, I described to a large language model how I use Prontosan in the OR, and then asked it to provide me with an image based on the description of my use. And that picture on the right is what you see there. I thought that was pretty interesting and probably pretty close. So here's the problem, right? Surgical site infection remains the single most important problem we have in all surgical specialties. 50 million surgeries a year, and if you look at that, just that 3-year time span, 2006 to 2009, almost 2% of those cases got infected. That is a staggeringly large number. When you start to break it down into certain surgical specialties, their infection rate's even higher. But look where we're at in orthopedics. Now, we certainly like to be the leaders in a lot of things, but this is not the one we want to lead in, and we're crushing it. So we are not making a significant difference when we talk about everything that we've done prior to Prontosan. These numbers are, especially for somebody like me who's in a bundled payment system, these are crushing numbers and crushing data, right? So what am I trying to avoid? Readmissions, ICU admissions, and mortality. We're not doing so good there. When I look at the financial impact of that, surgical site infection is the single most expensive event that we have in surgical medicine. If you think about $90,000 on average per surgical site, per prosthetic surgical site infection, and then you add that to the numbers we talked about previously, that is a massive amount. $10 billion annually is from several years ago. It's about $30 billion today annually. Average length of stay, almost 10 days. In a small physician-owned hospital, that is unsustainable for our facility. We don't have the beds. We don't have the ability to care for a patient like this who's this sick. So when I started down this road, I was wondering, you know, how did the guys that I trained under pick the irrigation solutions that they picked? And it just seemed to be, well, that's what I saw during my training, or that's, you know, what we have available to us in the hospital. And it was, you know, a myriad of all these things. Every single surgeon in this room has put almost every bit of this into somebody's hip or knee, guarantee you, hoping that it's going to make a difference. Chlorpactin smells great. Hydrogen peroxide makes bubbles. So, you know, I feel like those things maybe move the needle and they're doing something. You know, for me, I had no reasoning for why I did what I did. So when I got out into practice, I started to think, okay, what am I going to use? I'm a, you know, some is good, more is better kind of guy. So I developed this protocol. This is my revision protocol. So I would do a 5-minute soak. I'd start with hydrogen peroxide. I read some data that said if you do hydrogen peroxide before you do chlorhexidine, you get better effect from the chlorhexidine. So I thought, hey, if one of these things is good, I'm going to use all of them. I'm going to let them soak for longer than 90 seconds, which is the indication, and I'm never going to have infections. I'm never going to have complications. Well, that certainly wasn't true. Unfortunately, this paper came out about a week after I started using this protocol, right? So it crushed all of my thought process behind my reasoning. So when they looked at combining chlorhexidine and Dakin solution, we get a toxic precipitate. When you combine chlorhexidine and hydrogen peroxide, same thing. When you combine Dakins and hydrogen peroxide, now you get a potentially toxic gas in the operating room. And I was using all of this, and I was seeing all of this. I would develop a precipitate in the wound. If I added acetic acid to this, the tissue would turn grayish black, and then a gel would form on the soft tissue. The first time I did that, I was absolutely terrified. I irrigated that, trying to irrigate that grayish black color off the tissue, and guess what? It didn't come off. That was dead tissue. It's certainly not what we're looking for in the face of a potential infection. So what do? Do I just take this patient's skeleton, soak it in a vat of whatever solution? Well, here's the answer, and you know, the very wise Dr. Froimson taught this saying to me: the solution to pollution is dilution. We've all heard somebody say this at some point in our training, but like all great fellows, I added to what he taught me, and this is the real answer. It's the solution to pollution is dilution with the right solution. You can't just dump anything in there. You can't, 20 liters of saline isn't better than 2 liters of saline. So you got to pick the right solution, and you got to know why you're using it. So I said to myself, what are the things that I want in the perfect irrigation solution? I want it to work fast. I don't want to be in there for an hour staring at the clock, waiting for this magical soak to break down biofilm and kill whatever's in the knee. I want it to be broad spectrum. So I want it to work against gram-positive, gram-negative fungi, yeast, and viruses. I want it to be bactericidal. I want it to be bacteriostatic. I want at least a 5-log reduction in my colony-forming units, and I need to sustain that inhibition of growth over time. I need it to be effective against biofilm, and I need it to prevent future biofilm formation, and I need it to work in the face of what we have in every surgical site, which is blood, protein, fat, and debris. So this is the thought process. This is one slide that kind of summarizes his entire talk. These are the things that go through my head when I'm trying to bring a patient to the OR. Doing this 1,300 times a year is pretty difficult. So managing all this is overwhelming. If you don't have a patient that's willing to engage in this process, you're already losing. So I assume that my patient has done none of the things that I need them to do, and I try to optimize everything that I can do in the OR and after surgery to get them a good outcome. So this is how my journey began, right? So, and by the way, for anybody who's worried about AI taking over the world, that's an orthopedic surgeon with a stethoscope, so clearly has a lot of training left to do. So we're okay for now. I found a paper called The Consensus on Wound Antisepsis, published 2018, and it had all this stuff that I was looking for. So it kind of had a little bit about every one of these irrigation solutions. When was it effective? In what scenarios was it best? How long did you need to soak? What environment did it, was it optimal for? I had never heard of this paper. I had never seen this paper, and it was game-changing for me. I had no idea what PHMB was. Never heard of it, never seen it, and so I started looking at the data, and it's pretty overwhelming. PHMB had greater antimicrobial effect than chlorhexidine, and if you look at Irricept, 0.05%, they're looking at 2% chlorhexidine, 3%, 5% chlorhexidine. Put that in a knee and see how well your wound heals. You're in trouble. It was better against biofilm formation. It broke down biofilm better. When you get to 2 or 3 or 5% chlorhexidine, you start to see severe reactions. I have 2 patients who had intra-operative reactions that we had to actually stop the surgery and get them to recovery from a severe reaction to chlorhexidine. It's not tissue toxic. In some countries are even taking that tissue toxicity or taking chlorhexidine away because of that tissue toxicity. So the consensus, right? Where are we going with this? Well, PHMB was the #1 choice to prevent surgical site infection, the #1 choice for critically colonized wounds, the #1 choice for multi-drug resistant colonized infected wounds, and the #1 choice to decontaminate acute and chronic wounds. I think that covers everything that we're trying to do as surgeons in the operating room. That's #1. That isn't an industry-sponsored paper. That is a nationally recognized board of professionals looking at all the data and coming to this conclusion. It's the most frequently used antiseptic in orthopedic surgery across the world. Why isn't it that way here? most of us are hearing about PHMB for the first time maybe today. That's a shame. PHMB appears to be the best eligible antiseptic for patients who already have a septic joint. There's significant decreases in MRSA when you use PHMB in a clean surgical site. So I won't go too far into this because I'm not smart enough to do this part, but there's a surfactant that has a hydrophilic head and a hydrophobic tail. That allows the surfactant to capture this debris that we're irrigating out in the wound and take it out instead of leaving it in. So that's a really, really important part of this. So when you combine PHMB with betadine, you get a really powerful product. This is my protocol. So I wanted to develop a protocol, and then after this, I wanted to find out, am I really making a difference? I didn't want to just take, anecdotally, we all drink the Kool-Aid every once in a while on a product and fall in love with something. I fell in love with this product immediately. You could see a change in your wound. When you irrigate, you see a dilation of the arterioles, the tissue pinks up, it looks healthier. It's one of those products that you can see working, which always makes me happy. But I started off using saline through the case and then Prontosan in the end. And my PA said, why are we doing that? We already know saline doesn't work. Why don't we just skip the saline? So we went to a 1 liter bottle of Prontosan. When we make incision, we use Prontosan. When we open the joint, we use Prontosan. We irrigate through the case, and at the end of the case, we irrigate with Prontosan and we leave it in. You do not have to rinse this product out. For revisions, I do the same thing. I just use 3 liters instead of 1 liter. You saw the data previously. You don't have to leave it soaked for forever. 60 seconds, it's bringing those numbers down immediately. So I thought, gosh, I love Prontosan. How do I use more Prontosan? That made Jason very happy. He loves that question. Well, I started to look at the use of the wound gel. So they have a wound gel that's a little bit waterier, and then they have a wound gel X, a little bit thicker. And I wanted to see if the wounds that I was seeing in the office, if I could make a difference there. Every one of us is writing prescriptions for doxycycline and other antibiotics. We're not moving the needle. Many times we're doing that for the patient's comfort level. We know we're not going to really do much to heal that wound with that antibiotic, but we do it every day. We're not practicing good antibiotic stewardship. And so I thought, let's see if this makes a difference. So the very first patient that I used wound gel on, this is the outcome. This lady actually called me the next day and said, can I buy stock in this company? It was dramatic. It was overwhelming. I bought my first case of Prontosan wound gel that day. So that's in my office every day. Every patient who comes with, delayed wound healing, we give them Prontosan gel, we give them a protocol, they do wet to dry dressing changes. It's easy to follow and they can see it working. That's the biggest impact for me. If they can see it working, they'll be compliant. So then a brilliant surgeon decided to study whether this really works or not. So surgical site infection, obviously we've established, that's a big problem. So the protocol that we developed earlier, I decided to take a look at. So we looked at antimicrobial prophylaxis guidelines for SCIP. Every patient followed the same SCIP guidelines. So we tried to standardize that portion of it. Then we took 308 consecutive patients who were considered high risk. We defined high risk as a patient who had 3 or more diagnoses from the Charleston Comorbidity Index. And then we went and looked at their data retrospectively from the registry. And over an 18-month period, we had 0 of those 308 patients with a periprosthetic joint infection. Now, I think that 140,000 is a gross underestimation of what we saved the hospital, but the journal didn't like the number that I put in there, so we decided to play nice. Then I thought, well, look, let's see if that same data, if we get that same data with revisions, because really revisions are a much higher risk procedure, they're a longer procedure, so we tried to duplicate this study. We went and looked at a retrospective review of our prospective data through the American Joint Replacement Registry over about a year's period, 85 revisions. 72 knees, 14 hips. 73 of those cases were for aseptic reasons, and then we had 12 or 13 for deep infections. We followed that same skip guideline. We grabbed that data from the registry, so it was independent of my ability to have bias on that data. And then we had 2 patients we lost to follow-up. And then at 90 days, we collected this data at first, and we had 0 infection rate at 90 days, but that wasn't very exciting to me, so we decided to hold off and collect that data at a year. We had 0 infections or reoccurrences from that patient population at a year. I didn't expect the data to be this good, and I'm really impressed by what we found. So if we're going to circle back around those key factors that we talked about earlier, I think we're going to check the box on every single one of these. There isn't a single thing that we wanted to accomplish that we're not accomplishing with a single irrigation solution. No rinsing, doesn't damage our implants, and here's the big one. There's no resistance, and it works synergistically with antibiotics. If I gave you that list and said, I got one solution, it's in this little bottle, it takes about 90 seconds for it to work, is anybody not willing to give this a try? I think you're making a mistake if you don't. This is our opportunity to make a difference. This is a huge impact on our patients' lives. There isn't a single guy that can't think of somebody right off the top of their head that lives were destroyed by a periprosthetic joint infection. I think we all could come up with a pretty long list. And when it happens to a patient, it's devastating. And I know as a surgeon what we're about to go through over the next 2 years. If this bottle saves even a percentage of those patients from going through that, it's worth every penny. It's safe, it's efficacious, and it's certainly cost effective. Thank you.
Great, thanks, Paul. You'd like to see a little more enthusiasm next time. That was great. So now Dr. Viktor Krebs is going to talk to us a little bit more about treating infections, about revisions, and kind of some additional uses that may show the promise of Prontosan. So Viktor, thanks for being here.
Oh, thank you for inviting me. So I titled this DARE for PJI in 2024, Application of Advanced Debridement Concepts. We've been doing this for a long time, using different things to try to get rid of infection. Obviously, at the Cleveland Clinic, we have one sent in every day. So our fellows, our residents, co-staff, we're all taking care of PJI continuously. So this is something that's evolved. A lot of what I'm talking about is under study, and a lot of it is not on label. Here's my disclosures. Nothing to do with this talk. So I'm going to start off with some x-rays. Everyone wants to see a case review. So this is a 75-year-old male, 6 months status post right total knee replacement. He's 14 years status post the other one. So 6 months later, he goes in, has a tooth extraction, a jaw infection, and ends up with a systemic infection with what ended up being strep mitis oralis. So here's his x-ray, 6 months post-op. You can kind of see the little robotic markers there where the pins went through. But he comes into the office with a hot, swollen knee, fevers and chills, CRP elevated, SED rate on the rise. His aspiration, 10,500 white cells. So if that comes into your office, you're washing it out. You don't need a culture. This is going to the OR. So this patient went to the operating room. And this is one of the ways that we're using Prontosan. We're combining it with an ultrasonic debridement system, in my opinion, the best of both worlds. And this has basically occurred. The system that we use, the ultrasonic debrider, has been out for 15 years. And it requires the use of some type of antimicrobial solution. So it ultrasonicates and suctions at the same time. And if you just do it with saline, you actually make the patients worse by driving the bacteria into the tissue and creating a very negative atmosphere. So we've found out over time that you've got to use something with this system so that the bacteria are neutralized the moment they're ultrasonicated. The first thing we used was bacitracin, foamed up, couldn't see anything. We finally got to Prontosan, and Prontosan came into the US in 2 waves. The first time it came in as a nanoparticle and a device. So we had a hard time getting it into the Cleveland Clinic when that occurred. And then when it was reintroduced, it was much easier to get in. So the team here has worked really hard to make this easy to get into the hospital. The cost is very, very applicable to what we're doing. So this just shows the ultrasonic debrider, and I felt that it's probably best just to show you videos of what we do. So the Prontosan has a surfactant and the PHMB. These are nanoparticles, and they are there to get rid of biofilm. If you add that to an ultrasonic system that's going to irritate the biofilm off of the metallic surfaces, we've hypothesized that you're basically going to end up with a much better debride and retain and potentially a better long-term result from this. So we're currently studying this. We've got a prospectively collected retrospective cohort of patients, but this just shows what we're doing in a total knee that has an acute infection. And in this case, the infection was not identified before we went to surgery. We had no idea what was actually in there. And it's important, if you looked at the last video, the polyethylene was in. Polyethylene then needs to come out. You need to get into the back of the knee. You need to debride all of the metallic surfaces. So you can see with this device, we're moving it around on every surface that you can get to. The patella is also done in a similar manner. And it's important not to touch the metallic part of this ultrasonic device to the metal. I turned the sound on this off because it is absolutely intolerable screeching. It does. It sounds like nails on a chalkboard. But if you go into every one of your debride and retains and you use a biofilm destroying agent and ultrasonication, I think you're going to end up with a better long-term result, and hopefully we'll be able to prove that. Our anecdotal results are very good. I think our return rate for infection is very low, but we're really quick to jump on these. Hemostasis is also critical, so once this is done, I let the tourniquet down and I treat any bleeding. You don't want a hematoma in a wound that you just scraped out, so if you've got that, you've got to take care of it before you close. And this just shows what the wound looks like after it's been debrided. You can see the x-rays of the patient post-operatively. So new poly, tourniquet down, and DARE complete. So our goal with this is to eradicate biofilms without replacing the implants. I think every one of us in this room wants to go into the operating room in an infected case and not cut everything out. You know that taking everything out and putting in some type of a spacer, be it a static or a mobile spacer, creates a lot of morbidity for the patients. When you go through the literature, though, it's really, really, it's humbling to see the success reported with staph between 13 and 90%, gram negatives 27 and 94, and strep 40 to 94. So these rates of cure with debride and retain are so far out there that you can't even believe it. I mean, the range there is just unacceptable. There are some more specific studies that show that there are better results, but basically what you're seeing here is a coin flip. So if you have Staph aureus, it's 50-50, gram negatives, you've got a 68% chance. Strep is 58 and Enterococcus is 51. So in most of these situations, we're really not doing that well with what we've done in the past. And I think what most people have done in the past is they'll open up, they'll do an aggressive synovectomy, they'll rinse with solutions for different amounts of time, and then get out of Dodge. This is an article, one of the most recent ones, on the debride and retain. 970 patients in a systematic review and meta-analysis ranging from 18 to 92. The success rate ranged from 55 to 90% in the articles that were there, with a mean value of 71%. So if a DARE procedure is going to give you 71% success, I would tell you that you should be considering it in every acute infection. This is obviously not for the chronic infection and the infection that's been there with the draining sinus tract. This is another procedure that's out there, DAPRI, debridement, antibiotic pearls, and retention of implants. That just shows a picture of it. I've found that putting the calcium sulfate pellets in there creates an osmotic environment and actually results in a lot of swelling. So we tried this and kind of went away from it after doing the ultrasonic debridement. This is another study that shows that in revision arthroplasty, 88 patients who underwent a DARE after a revision within 90 days, between 12 and 19, had a success rate of 68% after 2 years. So this is good. So you've got revision surgeons who are very, very adept at debriding and synovectomizing, and you're getting a 68% on a revision. So this is good, but I think if you apply more advanced techniques and modalities, I think that we can improve this even further. This is just going to show a case of one of my disaster cases. So I didn't create this. It came in to me like this. 57-year-old DDH, multiple revisions. But if you look at that femoral stem distally, that's not coming out. If you take that 57-year-old stem out, you don't have any femur left, and you probably don't even have enough room to put a stem in the distal aspect of it. But they came in pain, swollen, with P. acnes. This just shows the stem and why I didn't want to remove it. So this was our spacer. So we went in, took the socket out. We did a dual mobility cemented spacer and filled a defect with an augment, but we retained the stem, ultrasonicated it, and used Prontosan around the top of it. This was in the first wave of Prontosan. So this was the spacer. So we put cement around the top of the implant. We debrided it with the appropriate solution and ultrasound, and she disappeared. So 5 years later, she shows back up in the office with this, which you would expect. This was not designed to be a weight-bearing spacer. This patient was all over the place walking around on this. So you look at the x-ray and you're like, oh my God, she's infected again, here we go. But we did all of the workup, and in this case it was sedrate CRP, aspiration, SPECT CT with WBC scans. There was absolutely no evidence of infection whatsoever. We did go in and we put on a bipolar and assessed the defect, and this defect was not reconstructible with any augment combination that I could come up with. So we put a bipolar in it, debrided it, cultured it, and then did a custom implant. So in this situation, prior infection with C. acnes, debride and retain, use of Prontosan. In these situations where you've got a well-fixed stem, there are times that you're not going to take stuff out, and I think using advanced technology to do this is the best way to go. So here's another one, debride and retain plus. I love the plus. So 14 with debride with conventional DARE. The DARE plus is modular component exchange and stem retention. So that's the case that we just did, and then there's 21 with two-stage revisions. When you look at this, the two-stage, the 2-year reinfection-free survival was only 25% for the DARE, but was 60% for the DARE plus or for two-stage revision. So DARE plus and two-stage revision in this study were equal, and I think that's pretty important. The 5-year amputation-free survival, 84% for DARE plus or two-stage and 48% for DARE. So these are really important numbers. When you're dealing with cases like this and patients' limbs that are at risk, you should be thinking about a DARE before you do it. So in a case like this, DARE is the first line of treatment when you have an infection. If you take this out, you're basically dooming this patient to an amputation. So reinfection-free, reoperation-free, and amputation-free survival was similar between DARE plus and two-stage revision at the 2 and 5 year marks. So I think this is a great study. It shows us that we can do things in a better fashion, and I think that this system that we've got with effective biofilm busting solutions and ultrasonics work. So here's a 67-year-old male construction worker, had a Birmingham resurfacing done. He weighs 348 pounds and 6'5", So this is not fun. You're not going into this saying, yeah, we're going to have a great day in the OR. So when you look at this, they come in with pain. First thing I'm thinking about, pseudotumor metal ions. So we got metal levels, and for hip resurfacing, a chromium level of 3.2 is pretty normal. So after we got that, SED rate CRP was 19.8 with normal being less than 0.5. So obviously we were dealing with an infection. He was seen initially at an outside hospital and they didn't know what to do with him, so they shipped him back to the clinic. We got an aspiration and he had 187,000 white blood cells in his hip. It doesn't get any worse than that. We didn't have an identification, but this is obviously going to the operating room. In a case like this, there's nothing to exchange. So you either debride it and retain it or you excise it. This guy was adamant about not having his hip taken out, as was I. So this is a perfect situation for a debride and retain. So it did grow Staph aureus out later, and I'm just going to show you how we use this system with the Prontosan. So this just shows soft tissue debridement. So any soft tissue area that's not healthy looking, we scrape it out with the curette end of this. On the metallic surfaces, we run the ultrasonic device over the metal, hovering over it so that it doesn't screech and scratch and make horrible noises. But this is actually, if you look at it compared to using a scrub brush or a toothbrush or some other method of debriding the metal, to me this makes a lot more sense. And in our early clinical results and for these patients, we've seen a lot of benefit. And you can just see when you look at that video how this thing is creating a layer of biofilm busting fluid on the metal. So it's irritating the biofilm off, it's delivering the biofilm busting solution, and you're going to get the best possible. So this is us reaching down into the socket. Probably the most important thing to see there is that suction tube is full of fluid. That fluid and the debridement on the socket surface is also critical because the biofilm's obviously there. And this just shows it getting in a little bit deeper and digging into the hip. I'm beating the dead horse here. So nanoparticle ultrasonication has been published. There's a number of people looking into this. It definitely shows in vitro studies that sonication plus a biofilm busting solution is a great option for reducing all biofilm off of a metallic surface. So we're translating that actively into patients in situations that are very difficult. So the Prontosan ultrasonic DARE, I think, is going to become something real. We're going to have some data coming from the Cleveland Clinic, and I'm going to be encouraging the company to support further studies on this and take this to another level. So I think a DARE should always be considered. I prefer to have an organism identified. So if you have a chronic infection or an MRSA infection, you have to think really close about how you're going to treat this. Those are the ones that tend not to do well. You need to have an organism that's sensitive. I think all acute infections, it's something that you should consider. All non-draining frail patients, if you do a 1.5 stage or a 2 stage in them, I think that you're going to put them at risk for problems. Obviously, any extensive reconstruction that's not easy to remove, and a lot of these end up on chronic PO suppression. Thank you.
Great, thanks Victor, and thanks to the entire panel for, I think, some really outstanding talks and outstanding, actually, information that I think is really practical. We want to open it up for questions. I think there are microphones out there if you guys have questions. And while you're doing that, Victor, if people aren't using Prontosan with this ultrasonicator, you said they shouldn't use a saline or something that doesn't have an antimicrobial. Are people doing that? Are people using just saline?
With the ultrasonic device? I mean, when it first came out, it's actually that device is used for bone debridement in the cranium. It's used for wound debridement. we were one of the first places that actually started using it in infected arthroplasty. So when we first started using it, no one told us anything. They're like, okay, here's an ultrasonic device. And then the more I read about ultrasonic debridement, there were a couple good wound studies that said if you don't use some type of antimicrobial, putting vancomycin, bacitracin, something in the irrigant, what would happen is you'd blow that bacteria back into the tissue, and then it would actually create a worse infection. So as it's debrided and suctioned out, it's got to kill that bacteria the moment it's released. So when you go back to the basic science, when that surfactant gets the debris off the implant, it needs to kill it and then suck it out. And that's the idea behind that.
Great. Really great stuff. Yeah.
Reed. Is there any reaction to using Zin Relief with your product inside the knee joint?
Do any of you have any experience with Zin Relief or using it with Prontosan?
No, what is Zin Relief?
It is a gel that is a slow releasing, pain relieving medicine.
It's bupivacaine and meloxicam, and I haven't seen any data on that. I mean, I've tried.
Have you used both? I mean,
Nope.
together? You don't use
Nope.
both, so you don't know.
I mean, I have used both. I've not used them together.
Okay.
Yeah,
won't
I
even
think
let
the,
us have
I
it
think
at
the
the
answer,
clinic.
we don't know that there's a contraindication. We don't know. So I think that's just an unknown. I don't know. Yeah. Yeah, there are surgeons who are using it that we know of and haven't reported any challenges, but we don't have a lot of data on that. Are there other questions? So, Paul and the rest of the panel, but start with Paul. People might say, look, I'm willing to use an antimicrobial agent, whether it's, iodine or Prontosan, on my high-risk patients, but not on everybody.
Yeah.
And you clearly say, BS to that. Everybody's high risk. So how would you respond to people who say, I'd rather use it selectively than across the board?
Yeah, I mean, I wish it were true that I could see preoperatively who was going to get infected and who wasn't, but you can't. So we all have cases where healthy 55-year-old male, not obese, taking 2 medications at home that gets infected. Unfortunately, we can't control for, dogs licking wounds and all the things that seem to happen in and around surgery, even when the patient has what they think are their best interests in mind. And so there's no patient that isn't at risk enough for me to use it.
And the way I look at it too is you have to consider the cost of every intervention that you do, right? We know prosthetic joint infection is ridiculously expensive, and if you can do something that appears to have significant effects for low cost, then I mean, to me, it's really a no-brainer. I think you do those low-cost interventions, and you get a lot of bang for your buck.
Victor?
So I had some big concerns about cytotoxicity of dilute betadine, and what we were given, obviously our institution's very cost conscious, so they would give us a sterile betadine package, and then it would be randomly diluted, and then you would put it in your wound, and then you'd put a press fit implant in. And I had huge concerns that that was not the ideal situation for a biologic fixation surface. So I went and looked at data, and I presented to the clinic, and I said, listen, we need something that we can put in, leave in, not have to wash out, and not have it be detrimental to the ingrowth of our implants. So that's how I started using it in primary joints. With this IV solution shortage, now everyone's using it and everyone loves it. So in a primary joint, you get one of the small bottles, and so just like Paul's protocol, we do exactly the same thing. and we irrigate multiple times with that. We've taken the pulse lavage out. So if you take away the pulse lavage and you bring in a bulb syringe and Prontosan, you're actually saving money, and you're probably doing a better job for your patients. So if you really look at the big picture of cost, you can walk in and justify all of this. And that's how I've ended up there. And I do think it's going to make a difference. It's something that's been used in Europe forever, and it kind of doesn't make sense that we haven't used it.
And I would say anecdotally too, I mean, you see improved wound healing, but I see a reduction in pain, in post-op pain. I don't have any data to support that, but anecdotally I see that it's a really big benefit for me, I think, post-operatively.
There was a question out here.
Yeah, just one, a couple of questions actually. One of them, I might have missed it in the presentation, the optimum contact between the solution and the tissues. For how long would you like to leave that solution in contact with the tissues for? Intraoperatively, obviously. And the second question is in relation to the indication/contraindication for a DAIR. I see you very enthusiastic in doing a DAIR procedure for many patients. What's your contraindication for performing a DAIR?
So let's start with the first one, which is, how do you use Prontosan in your practice? I mean, Paul, I think you addressed it. You want to?
In the slide that my colleague presented, I think it says action within 60 seconds. So, I mean, it's very rapid onset. I use it for at least 90 seconds of contact time, but I'm literally soaking the wound in Prontosan throughout the entirety of the case. It's active within 60 seconds, though.
I do the same thing. I mean, basically, so you never want the tissue to desiccate, and as you go along, we're just putting irrigant solution in there. You don't have to wash it out. It's not going to kill anything. So it's continuous bathing the tissue with a squirt of Prontosan the whole time. And then we wash it out a little bit more before we put the implants in, and then obviously leave it there. And that's in both hips and knees.
Curtis, same?
Yeah, same. I think, when you have like the 300 ml bottle, like just squeezing that, I mean, it takes about, 40, 50 seconds. It's not that long, but I mean, it's plenty of time. And then I think that's the key. You're not having to remove the solution, so it's there. I mean, it's that stuff's staying in the wound for the rest of the case. So.
Yeah, and I have to say I have a lot of respect for our colleagues who looked at betadine and povidone iodine and sort of really kind of set the stage that using an irrigation solution is important. And so we owe them a debt of gratitude for kind of highlighting that wounds are contaminated, and wounds should be decontaminated prior to the surgery, the end of surgery. The challenge is when you think about it from a holistic perspective, contamination occurs throughout. If you're waiting at the end and then, magically 3 minutes, you're going to put it in, and then if you actually see Jay, my friend, Jay Parvizi, he goes, and then quickly wash it out, right? Because there's a notion that betadine isn't great for tissue, and so you've got to quickly wash it out. And then, you go on with your case now, again, unprotected while you're closing, et cetera. So it just made sense to us if there is an alternative that has the potential to be as effective or, as you saw from the basic science, likely more effective, but you don't have the cytotoxicity and you can use it throughout, it's logical. And so, again, a lot of respect for the work that's been done to this date. We just think that we have a product that allows us to move further.
There was a paper published recently that said, I think it was 88% of wounds are contaminated at 80 minutes. 88%. That was shocking to me. I knew we had some contamination, but at that percentage, it's essentially guaranteed that patient, the host has been exposed. If you have a poor host, you've got a problem on your hands right there. And when you do enough revision work, I'd be really happy with an 80-minute case. They just don't usually happen that way. And so I'm starting to think, 90 to 100% of my revision cases now have been exposed to a polymicrobial infection in a host that's already compromised because we're in a revision scenario. It's just a bad situation, and if you don't have a plan, you're in trouble.
So the second part was, kind of what's your contraindication for a dare? So let's just go down the panel, quickly, maybe 1 minute. Curtis, you want to start? When you do it, when you don't?
Yeah, so I think for me, I really do want to know the bacteria for a dare. Any kind of soft tissue reconstruction, I don't do a dare. And, if they're really, I think, host status varies because some of the absolute worst patients actually are not going to do well with a two-stage either. So those are situations where I will consider a dare. But for me, I like to know the bacteria, and I want to make sure there's a soft tissue envelope that's reasonably intact.
Paul?
I don't know that you're going to like my answer, but it's a continuum. So I look at the patient, their age, their preoperative medical status. I of course, consider the time frame for how long the symptoms have been present, but I think most people don't really have a good understanding of when their symptoms truly started, so I kind of don't rely on that very much. But I think if they have the potential to fight an infection, I will lean towards a dare, even if I have to push the length of time that infection's been present. But if it's a poor host and that we've got many, many hurdles to jump, then I'm starting to, regardless of the time frame in mind, I'm thinking about alternatives. I present the numbers to the patient, and I engage them in the decision-making process.
Victor, just as you're answering this, if you're in there, you're intending to do a dare, what do you see intraoperatively that might change your mind?
Actually, that's what I was going to say. So if you saw that knee that we were debriding, it was well fixed. There were no scalloped interfaces. There was no evidence of osteomyelitis or between the implant and the bone. So if you get in there and you see erosions with membranes in it, the parts are coming out because you know that it's under the implant and there's no way you're going to save it. So there are those factors that you get in there, and if there's a big eroded area on the medial femoral condyle underneath the femoral implant, you're out of there. I mean, if you don't take it out, then you're going to create a problem. Then it's a decision, do we do a 1.5 stage and put an implant back in, or do we do a 2 stage? And I usually, at this point, I'm reserving the 2 stages for people who have extensor mechanism problems or tissue deficiencies. So in those, you're going to put a static spacer in. You saw one of mine up there. And I think those heal better that way. You also kind of give them, those are the ones that are more likely to end up amputated. So you give them an indication of what a fusion's like. The mobile spacers are the less, the less nasty infections. And especially if you get in and you've got a sensitive bacteria, that 1.5 stage or single stage, if you want to call it.
Yeah, I was going to ask you that. I know there's another question, but just go down real quickly, starting with you, Victor. Are you leaning towards more 1 stage? People who say now 1.5 stage, if you're doing a 1.5, why not just do 1? So what's the thinking these days?
I mean, my 1.5 is essentially a 1.
Yeah.
So I do an all poly tibia, a CR, a PS femur, and get out of Dodge.
And you expect that to last for a while?
Yeah, and I have hundreds of people walking around on them.
Yeah, I'm the same way. I've moved toward, if I'm going to take the implants out, what I put in, I'm hoping is going to stay in. I have a pretty frank conversation with the patient that, look, if it loosens, we'll take it out. But if we don't have to touch it, we're never going to touch this implant again. I build it as though it's going to stay in, and I think about 2-stage procedures quite a bit differently. So I'm gap balancing those knees. I'm building spacers out of cement augments. We're thinking about them much differently than a get in, tear it apart, like a fire sale. Everything must go, and slap something in there and get out of the OR. It's much closer to how I think about a primary or a 1-stage revision now. So I plan on my 1.5 stage being 1 stage.
Yeah, I think similar. I use real component spacers, so a CR femur and all poly tibia. And I tried to get a balanced knee at the end of the case. So I'm the same way. I'll put cement augments on the femur if I need to. I'll augment the tibia if I need to. Whatever has to be done. And then, you know, I talk to the patient ahead of time and say, look, this is something you're going to be able to walk on. This will be a functional spacer. It may or may not function as well as a knee. And I think, you know, individually, they're going to decide whether that knee is an acceptable option for them going forward or if not. And if they, you know, as long as we can get rid of the infection, if they don't love it, then I talk to them about doing a formal, you know, second stage. But I mean, most of them go in and I'm expecting it to stay for a while.
So the static spacers are kind of out for most of you guys?
I'm the same with Victor. You know, big
rare.
soft tissue problems, extensor mechanisms, and even actually, I'm doing some articulating spacers on extensor mechanisms and just locking them out in extension for.
Yeah, great. There's a question over here, I think.
Victor, and about the ultrasound you use in your presentation. What kind of ultrasound that's a high frequency or low frequency? And what's the purpose of that? I mean, the real purpose of that ultrasound to break the biofilm, break the biofilm and kill the bacteria.
So the system is made by a company called Mysonic. Someone bought them. It's a variable frequency, so you can turn it up and down, and you can change the flow of the fluid based on what you're debriding. So it's a pretty versatile system in terms of the ultrasound that it puts forth. I usually use it on the higher frequency rather than the low frequency because that's been shown to be more effective against biofilms on metal. So I have whole talks on ultrasonic debridement. Obviously, we don't have time for that right now, but there's a lot of good evidence out there that shows that ultrasonicating a biofilm, obviously we use it for diagnosis. So you send your sample and your implant in, ultrasonicate it, get the bacteria out, and then culture them. We're doing the same thing here. We're just doing it in vivo, and we're using it as a treatment.
All right, yeah, go ahead. All right, real quick, do you take everything
I'll go
down?
really fast. So it's prep and drape, dirty side, and then we clean it out, do whatever we're gonna, and this is the same for a dare or a one stage. So there's the dirty side, everything is done. Once that knee is clean, we pack it, cover it with a stockinette, and then change all the drapes, take the dirty table away, put all new suction and stuff on. So when we're closing it and finishing it up, so if it's a dare, the poly goes in on the clean side. If it's a one stage, the implants go in on the clean side. So everything is clean. There's no debris. It was probably on the videos, so when I showed the ones that were done, that was clean drapes.
Same for all you guys?
Pretty similar. There's a video on Vumedi on a draping technique for that, and it's really good. And you just peel off the outer drapes. You got brand new clean drapes underneath, clean table, all that. Same thing.
Real quick question. You guys have convinced me. I've been using the Irrigation, and it comes in a very convenient 450 cc bottle with the long, neat nose. You can spray it in there. What are y'all using? What size? What's the product package like?
There's a 1 liter bottle and a 350 ml bottle, and then there's smaller bottles for office use. I use the 1 liter bottle, and you can hook it up to a pulsed irrigator. You can spray it into the wound. You can use a bulb irrigator, however you want to do it.
Yeah, one of the nice things is it's the only product that actually has multiple modes of use, so you can use it with a pulse lavage if that's your preference. It comes in a sterile, just like a replacement for Irrigation. You can squeeze the bottle.
I removed the pulse lavage because I've been using the bottle, and it's so convenient and easy.
Same.
So
So you can,
hospital is on
so there's the
Yeah.
exact same product available with
Okay.
this sterile
Yep.
bottle. Yeah. Sorry? You know, so cost is one of those things, it depends on your institution, negotiation, group purchasing, and all that stuff, but it's on par with Irrigation, so I think it's around $60 a bottle for the squeeze bottle, And I think the leader, all right, Paul, what do you guys pay for the leader? You own the
honestly,
hospital.
I'm kind of ashamed that I don't know. It doesn't matter to me. I'm using it. It's amazing.
It's like $100,
Yeah.
I think, for the leader, something like that. 119. So, all right, we're out of time. I just want one word from each of you on PHMB future uses. If you could tell the company, this is totally off-label,
Love it.
right? But if I could get PHMB in a different form, like on a coating on an implant or a,
Yeah.
all right. Paul, you want to start, I see.
I want to start. I've been dying to do this one. You saw the antibiotic beads. We've all tried to use antibiotic beads, and they stink. They make wound drainage. It's just everything you don't want in a post-operative wound. We need Prontosan in a crystallized form that can break down over time, that we can put in at the end of a case and slowly deliver low amounts of PHMB into that wound. It's
Victor, any?
Wait, so let's lyophilize it. Let's make it like,
Okay, we're doing innovation
Yeah.
right here.
yeah. So, I mean, get it in there, have it hang around for a while. I think that's the best way to knock down the contamination.
This is called
side of
product
it.
development. All right, please join me in thanking our panel. It was a great session. I hope you enjoyed it.
Good job, man. This is fun. Good job.
Thank you.